Hi, everyone. I'm Jessica, and this is Dr. Krausner.
I will.
Thank you for joining us today. Before we get, the plan is to talk about intra-abdominal infections. Does anybody have any cases, though, before we get started? Or more interesting things than intra-abdominal infections? C. diff, because we can't have a echo without talking about C. diff.
I would have withdrawal.
Okay.
You want maybe before you start talk a little about that C. diff meeting we had at the now. What we're trying to do.
Sure.
We got to get a little.
Because you will get a little go through withdrawal. So at Renown, this last couple weeks ago, we had a multidisciplinary meeting with one of our intensivists, the medical director of the intensivist, a GI physician in town that does a lot of stool transplants, as well as our surgeon who's in charge of quality, and Dr. Krausner. Can't forget Dr. Krausner, infection prevention, and myself. And what we did was we agreed that there needs to be a standardized process for patients admitted to the hospital with C. difficile. There needs to be clear guidance on when to consult surgery, when to consult GI. And so right now what we're working on is going to the individual departments, surgery and GI, to get a consensus of when they should be consulted, one, and two, what should they do and what should their be approach once they're consulted. So what is the role of stool transplant? How are we going to do that? Who's going to do it? What route of administration, and so on. With surgery, are we going to be promoting the loop ileostomy, which is a colon sparing procedure? Are we going to push towards colectomy, and kind of standardize the process of loop colectomy first, or loop ileostomy first, then moving on to colectomy, and then obviously update our guidelines with the more recent recommendations from IDSA with regard to treatment. So we're really excited about that process. Do you have anything to add?
No, but there's so many options. You know, do you use surgery? Do you do stool transplant when you do it? So we're trying to come to a consensus so that we have sort of a standardized approach, and then maybe share it with the other hospitals in town so we all have the same approach to it. So it should be hopefully helpful to get that whole plan made up the next few weeks.
We were talking about the C. diff meeting. Do you have anything to add?
I'm sure you said it all.
Okay.
Any cases or?
Yeah, any cases or questions out there before we move on to the PowerPoint? Okay.
Awesome. So we're going to talk about intra-abdominal infections. We'll talk a little bit about diverticulitis as a component of intra-abdominal infection. But there are three major guidelines that I think that you should be aware of. The oldest are the 2010 IDSA guidelines that were jointly published by IDSA and the Surgical Infection Society. IDSA has not updated those guidelines, but the Surgical Infection Society has. So in 2017, they published their intra-abdominal infection guidelines. I also included here the GI guidelines for acute diverticulitis, which we'll briefly touch on in a minute. But these are the three most recent guidelines that we have available. Start with the basics. So intra-abdominal infection is really infection of any organ or organ space in the abdominal cavity, anywhere from the lower esophagus all the way down to the rectum. And these can be divided into two types, uncomplicated and complicated. Uncomplicated being it's contained within the organ. There's no anatomic disruption. So an example of this would be cholecystitis or even appendicitis that hasn't ruptured. These may or may not require surgery. It may or may not require antibiotics. On the flip side, a complicated intra-abdominal infection is when you actually have spillage of GI contents or microorganisms into the sterile peritoneal space. Surgery or source control is the primary method to manage these cases. Antibiotics are only considered as a supplement to surgery. Your most common pathogens with really any intra-abdominal infection are your gram-negatives, or Enterobacteriaceae, E. coli being the most common, and your gram-negative anaerobes, such as Bacteroides. You can get gram-positives, such as strep species, as well as Clostridial species, but they're a lot less common than E. coli and Bacteroides. You expand that, the bacteria that you're concerned about, the sicker a patient is and or if there's any hospital-associated or nosocomial type infection, or potentially even a recurrent intra-abdominal infection. At that point, you were really worried about Pseudomonas as well as Enterococcus. This management of intra-abdominal infections, is quite a spectrum here. First, you have to diagnose. You have to suspect and then diagnose. Typically, this is a CT, ultrasound if you're worried about the biliary tree in any way. And don't forget that with any infection, if they are septic, you should provide early goal-directed therapy. That includes fluid resuscitation, so NS or LR. But the most important thing with intra-abdominal infections is timely and appropriate source control. So this is consistent with the surviving sepsis guidelines. So source control is incredibly important in these cases. The majority of this talk will be focused on antimicrobial therapy, but again, I cannot stress that antibiotics are a supplement to source control in these patients. But let's briefly talk about source control. So again, arguably the most important part of treatment of an intra-abdominal infection. You can drain the affected fluid, you can debride necrotic tissue, and the goal here is to decrease that bacterial load. The peritoneal cavity is obviously, it's not, you get antibiotics into the peritoneal cavity, but it's not vascularized. So you're unable to present or really penetrate any large amount of bacterial load that's there. And so you really need to decrease that inoculum for your antibiotics to be effective. And source control can also, it basically transforms the environment so that microbial growth is impeded and your host defenses can really be optimized. The antibiotics that we have, this is not an all-inclusive list. This is typically what we use at our facility. When I'll talk about a few exceptions here. For a mild to moderate patient that's admitted to the medical floor or surgical floor, we'll use ceftriaxone plus metronidazole. That's going to hit your gram negatives, such as E. coli and your Bacteroides species. You can, if they're unable to tolerate a cephalosporin for some reason, you need to use a carbapenem, you can. We try not to use the carbapenems if at all possible at our facility. We like to reserve those for multi-drug resistant infections. So if we can't use a beta-lactam, we'll go to the cipro-metronidazole route, but only in patients with very mild disease who are very low risk of complication. And that's because of the resistance that's seen with E. coli to the quinolones. And I'll talk a little bit more about that on the next slide. For severe infections, we go piperacillin tazobactam. So mild to moderate, ceftriaxone flagell. Severe, we go piperacillin tazobactam. If we can't use Zosyn due to a penicillin allergy, we'll typically go cefepime plus flagell. At rare instances, we will use an anti-pseudomodal carbapenem. This is such as meropenem, imipenem are the two most common formulary agents that are out there. Severe beta-lactam allergy, H3N, metronidazole, Vanco. This is I really don't like this combination, but when you really need good E. coli coverage in a severely septic patient with an intra-abdominal infection, this is really the best option that you have. H3N will hit your Enterobacteriaceae, metronidazole will hit your anaerobes, and you're still worried about gram-positives such as strep species and these severely ill patients, and so you add vancomycin in to cover those. And you can always de-escalate once you get your cultures back.
What about meropenem in that situation?
I would prefer to use meropenem than H3N, metronidazole, Vanco.
Might be.
But if I can't use a penicillin or beta-lactam at all, we're unable to get a good allergy history. We have no documentation of them tolerating a carbapenem or a cephalosporin. It's a risk versus benefit scenario on what we go with. Here are some antibiotics that are not recommended for empiric coverage. Unicin or ampicillin sulbactam, E. coli resistance is very common. Fluoroquinolones, at least in the Reno area, E. coli resistance to quinolones is relatively common, so they should not be used empirically. You can use them as de-escalation if you have an E. coli sensitive to unicin or the quinolones, but again, not empirically. Anaerobic resistance is common with Clinda, so Clinda doesn't hit Bacteroides very well. Similarly, cefotetan and cefoxitin. So if you ever use cefotetan and cefoxitin for treatment, you can use these for prophylaxis, but for treatment, you need to add anaerobic coverage to them. And in those instances, I would rather use ceftriaxone metronidazole than cefotetan metronidazole because the cost is associated with cefotetan and cefoxitin are quite a bit more, they're more expensive than ceftriaxone. I do have tigecycline on there. In theory, if you read the books, it hits all the key components. It hits your gram negatives, it hits your anaerobes. But what studies have shown is clinically that doesn't pan out. It's inferior to our common antibiotic regimens, and higher risk of death when you use tigecycline for these types of patients. Do you have anything to add?
Yeah, so, traditionally you think of ampicillin unison is for intra-abdominal coverage, but, as Jessica pointed out, E. coli is your #1 enteric that you need activity against, and Ampicillobactam only covers about 50 to 60%. So unless you have an E. coli, susceptibilities, do not use Ampicillobactam for, appendicitis or diverticulitis, okay? If they're sick, you'd go with Zosyn. But, beta-lactamases are what makes E. coli resistant to ampicillin, so sulbactam overwhelms it. But sulbactam is very weak against it, so you have heavy production of beta-lactamases. And so just unison is not a good choice for intra-abdominal infection because of that poor activity against E. coli. And the other thing is, we see people doing ciproflagyl. We say, why are you on ciproflagyl? Oh, it was easy. Again, E. coli, for a community-acquired infection, E. coli, you need good activity against E. coli. And, for community-acquired E. coli, you probably have 95, 96, 97% activity with ceftriaxone. With the quinolones, it's 75 to 80. So, for an intra-abdominal infection, you're taking a crap shot there. 1 out of the 4 cases for empiric E. coli is to be resistant to cipro or levoquin flagyl. So, unless they're really you have a good allergy history, the ceftriaxone and flagyl is the way to go for community-acquired infections.
Any questions about any of that so far? So let's first talk about the intra-abdominal infections where antibiotics are not indicated. So there were a couple of studies out of Europe with acute uncomplicated diverticulitis that suggested that antibiotics provide no benefit for the treatment of those patients. And so the 2015 diverticulitis guidelines and the Surgical Infection Society guidelines have both come out to say that you should consider not providing antibiotics in patients with low risk uncomplicated acute diverticulitis, that provides no additional benefit than just supportive care and medical management otherwise. What does that mean for patients admitted to the hospital? It's hard to say, and there's just really no data on these patients. Historically, what everybody has done is ciproflagyl on anybody that comes in with left lower quadrant pain that they suspect of having diverticulitis, and that shouldn't be the case, especially on the outpatient side. I would withhold antibiotics in those patients if at all possible. Severe or necrotizing pancreatitis, the pancreatitis itself is not an infectious process. But necrotizing pancreatitis is at high risk of becoming infected. And so historically, what we've done is provide prophylaxis with an anti-pseudomonal beta-lactam and beta-lactamase inhibitors such as Zosyn or carbapenem. But studies have shown over and over again that there is no benefit, that it actually does not improve outcomes to prophylactically provide antibiotics for necrotizing pancreatitis. And this has been an incredibly hard battle to convince surgeons and physicians of from a stewardship perspective, but we continue to push this. And I think the hardest thing is that a severe necrotizing pancreatitis mimics infection. They're going to have a high white count. They could be hypotensive. They could be in respiratory failure. So we try to withhold antibiotics if at all. We may start them empirically, and once we have a diagnosis of necrotizing pancreatitis, peel those antibiotics back and watch very closely for decompensation. But those are definitely hard conversations to have. I don't know if you have anything to add about that.
I just don't even try to stop it.
But what happens is you start these broad spectrum antibiotics, and at 2 weeks, a lot of times they're still severely ill. We don't have a definitive diagnosis of infection. And then, and then 2 weeks later, it does become infected. We stick a needle in it, and now it's a carbapenem resistant Pseudomonas. We've had that happen several times. So I think there are conversations worth having, but they are definitely hard conversations. I won't lie to you. Circumstances where ultra short durations are indicated. So this is where you may only get a single pre-op dose, or if you give post-operative doses, you discontinue within 24 hours of that surgery. So a traumatic bowel perforation where it's operated on within 12 hours. You have a gastroduodenal ulcer that's perforated and they're able to be operated on within 24 hours. You can actually stop antibiotics within 24 hours of that procedure. Uncomplicated infections such as cholecystitis and appendicitis, as long as there's not rupture into the peritoneal cavity, you can stop it. Single pre-op dose is sufficient. If you do post-operative doses, DC within 24 hours. But what about everything else? So the IDSA guidelines in 2010 said, if you do have a complicated intra-abdominal infection where you have adequate source control, you can treat 4 to 7 days. And that longer durations of therapy have not improved outcomes. So that was in 2010. So what a group out of, I can't remember, I want to say Harvard or Johns Hopkins, I'm not sure which, published this. This is in 2015, they basically evaluated the IDSA recommendation of 4 to 7 days. So what they did is a prospective, randomized, open label, multi-center study. So I think there were 4 relatively large facilities involved in this study. In adult patients with complicated intra-abdominal infection that had adequate source control. Adequate source control was defined by the surgeon, so that could have been an open surgical procedure, laparoscopic, or percutaneous drainage. And people were randomized either to receive the experimental group, which was 4 days, no matter what, of antibiotic therapy post-operatively, or what is generally the standard of care, which is 2 days after the resolution of signs and symptoms of SIRS. So decreased white count, no fever, no tachycardia. And what it ended up being like 200 patients in each group. The median duration of therapy in the experimental group was 4 days versus 8 days in the wait until symptoms resolve, which is what the majority of surgeons will use, at least at our facility currently. And what they found was there is no difference in the primary outcome. I won't lie to you, there was still a 20% event rate. So the events being surgical site infection, recurrent intra-abdominal infection, and death. So events occur regardless of whether or not you treat 4 days or 8 days. The difference was the time to that event. What they found with this study is that the longer you treat, the more you delay the inevitable. So the time to event was 10 days if you treated with 4 days of antibiotics versus 15 days if you treated with 8 days of antibiotics. While they didn't find this with this study, but you could extrapolate that into longer lengths of stay, potentially morbidity associated with a longer length of stay. So really the key is this, is that longer post-operative antibiotic therapy does not improve outcomes, it only delays the inevitable. And they sliced and diced this data. I think they got 5 publications out of this data set. No matter which way they cut it, in terms of, they looked at people on concomitant steroids, they looked at diabetes, they looked at obesity, they looked at diabetes and obesity, they looked at, sorry, I skipped ahead. They looked at Apache 2 scores greater than 15, so the most severe cases that they had, and no matter which way they cut it, 4 days was equivalent to the standard of care. And in every way they cut it, all it did was delay the inevitable outcome of a recurrence if an occurrence happened. What about percutaneous drainage? I'm guilty of this. Previously I considered a true surgical procedure as better source control than percutaneous drainage. Because with surgical intervention, you can actually go in and remove that gross pathological tissue versus a percutaneous drainage, you stick a needle in and you drain that abscess or fluid collection. In theory, it sounds like surgical intervention would be better source control. So maybe with percutaneous drainage, you would need longer durations of therapy. And again, the Stop It trial, when they looked at this, they actually found no difference in outcome. 4 days with percutaneous versus open or surgical intervention. 4 days, no different than 7 days, except for the time to that event was extended if you had longer durations of antibiotic therapy. So that's the biggest piece of data that we've had since the 2010 IDSA guidelines. There's a group out of Vanderbilt that said this data is awesome, but I don't trust it. So what they did was, with the Stop It data, they applied the criteria of the Stop It trial. So 4 days of antibiotics versus standard of care to their population, their acutely ill population. So they only included patients with complicated intra-abdominal infections admitted to their surgical intensive care unit who had source control. And they found very similar results. In fact, they found worse results with longer durations of therapy after they adjusted with logistic regression. Longer durations of therapy were associated with treatment failure, not necessarily mortality, but definitely treatment failure. So what does this mean? I think this is very convincing data that 4 days should be the duration of therapy for complicated intra-abdominal infections with source control. And I include percutaneous drainage into that bucket. Now, not everybody has adequate source control. Not every surgeon will say, yeah, I had adequate source control after that surgery. And it's important to read that out note, talk to the surgeon that performed the procedure. But what about those patients? The guidelines say 5 to 7 days, no more than 5 to 7 days. And you can actually stop before that 7-day time period if your clinical assessment suggests that you can stop. So assess every day, see if their white count's resolved, no more fever, no tachycardia, and discontinue before 7 days if that's the case. What the guidelines also state that if you do not have the response that you want by day 7, you need to reassess for source control. That's because it's most likely a surgical intervention that's needed or a source control intervention that's needed. Antibiotics will not help in that scenario. In bacteremia, they suggest 7 days as well. This is very consistent with what we see with the bacteremia secondary to urosepsis or UTI, is 7 days with a gram-negative bacteremia is sufficient. They don't specifically call out Staph aureus bacteremia, probably because it's not a common, intra-abdominal infections are not a common source, but if you do have a Staph aureus bacteremia, minimum of 14 days. But gram-negative E. coli bacteremia, 7 days is sufficient for these patients with highly bioavailable therapy though. Do you have any comments about that?
I got this guy in the hospital and he had peritonitis. They took out his gallbladder. He had 5 days antibiotics. So I signed off. I stopped his antibiotics. I took a peek the next day and his white count was 18,000, which he was sitting up eating, but they said because of the white count, they not only restarted the antibiotics, they added a nasalide. And so he's still sitting there, I think a week later now, the Zosyn and nasalide doing fine, but they're treating the white count instead of the patient. So these are nice guidelines, but in reality, it's really hard to change practice patterns.
I totally agree. We're battling it on a daily basis, but the studies have shown over and over and over again that the antibiotics themselves do not prevent the recurrence. They delay the recurrence, which is not necessarily better. So here's a case. This is a patient that was discharged yesterday, a 66-year-old male in the emergency department, came in with right lower quadrant pain. White count was 15,000, otherwise stable. They did a CT of the abdomen pelvis, showed acute appendicitis, but not complicated by free air or abscess. So they diagnosed him with acute appendicitis. What would you do with this patient? Any takers? OR, good. Surgery. Get a surgical evaluation. How would you start antibiotics? I would go, you could make an argument one way or the other here. You could do, this is a mild case. He has an elevated white count, but this is somebody we would admit to our general surgical unit. This is not somebody we would admit to our ICU. However, he's 66 years of age, so if you were checking boxes in the guidelines, 66 is considered high risk. So if you wanted to go this piperacillin tazobactam route, you wouldn't necessarily be wrong. I would probably go ceftriaxone flagyl in this individual. Assuming the surgeon goes in and finds no complication, no perforation, you can stop that antibiotic within 24 hours of the procedure. What actually happened is that when the surgeon documented in his post-op note that he had found a ruptured appendix and had a fluid collection, and the appendix was partially necrotic. So, but no other complications were noted. So the question is, how would this change your treatment plan? Would you still stop within 24 hours of surgery, or would you treat it as a complicated intra-abdominal infection and go 4 days? I would go 4 days. So really 4 days of antibiotic therapy. If there was significant improvement, no cultures were actually done in this patient, which is pretty standard of care with an appendicitis. But you could de-escalate to the culture results if you got them back, or if you don't have any, potentially change to augmentin if on if everything improves within that 4-day time frame, but I wouldn't go beyond 4 days. What actually happened in this case, when I looked at this case yesterday, we were on day 6 of cefotetan monotherapy, being discharged on augmentin, a suboptimal dose for an additional 3 days.
How was the patient doing?
Doing fine, was being discharged.
So I didn't need any more antibiotics,
Right.
it's over-treated.
Mm-hmm.
And the 17, it's not a good choice. 17 is pre-op where you have, for elective surgical procedures, but doesn't give you anaerobes, which are, 99% of the bacteria there is B. frag, and the 17 is weak against it. So you should have been Rosefin plus Flagyl or 17 and Flagyl. And then, source control, exactly.
So, summary, no antibiotics for pancreatitis. I'm a big advocate of no antibiotics for uncomplicated acute diverticulitis, especially in the outpatient setting. DC within 24 hours of surgery for unperforated cholecystitis and appendicitis. Rule is 4 days if you have adequate source control with complicated intra-abdominal infections. 7 days if there's inadequate source control. That doesn't fit everybody though, I will say that. Occasionally source control is impossible and surgeons don't want to touch the patient. Those durations can be for a very long period of time, 3 weeks or more in some rare instances, but those are the rare exceptions, but they do happen. So the conclusion here, there will be failures, but it's not because you're short antibiotic course. It's a deficiency in the source control procedure or additional source control is needed. Longer durations don't improve outcomes, they just delay the inevitable outcome that will happen, whether that be clinical cure or failure that requires additional source control. That's my 2 cents.
I mean, if you're a doctor and you don't give somebody antibiotics that comes from diverticulitis, you're going to get the worst ratings ever on the social media. It says, I went to this damn doctor.
That time you could be, sending a e-script to the outpatient pharmacy, you could be counseling that patient that this is actually in your best interest, talking and counseling rather than dealing with your EMR and that e-prescription. Does anybody have any questions?
Have you guys had similar cases like this where the antibiotics were too long or not long enough?
We see it every day at Renown.
It's everybody guilty, right?
Actually, the best surgeons are our trauma surgeons. So the sickest patients, they are the best at discontinuing with 7 days. It's the surgeons that generally don't practice in the ICU that go longer durations, which is counterintuitive to me.
It's the pharmacist availability in the ICU.
It might be.
They're influencing it.
We do have a trauma ICU pharmacist that rounds daily and has been able to be in the conscience of our surgeons in the ICU, whereas we don't have that on our general surgical floor on a daily basis.
All right, so just in your own hospitals or clinics, look what people are doing and just see with this perspective, see how they're treating patients. Be interesting to see. Maybe they're overtreating, but that's like every disease, pneumonia, strep throat, everything's being overtreated. And the move is to really cut down as much as possible. Well, thank you, everybody. We'll see you next same bad time, same bad channel. Oh,
Thank you. Nice presentation, Jessica.
Thank you, Beth.
Yeah, we'll be back on, what will it be, May 17th, is that correct? I believe so, yeah.
Yep.
Talk about C. diff.
Thank you. Thanks a lot.
Thank you.
Thank you.
Leave me.